one, they use those formulas for so many years in a hospital, in their private clinic, and we collect them and then make it as our collection formula line. So this is very experienced formula that you don't have to try so many times to see the result. You don't think about that. You don't have to try and error for so many times to just find a one perfect magic formula for your patient. You can just use the collection formulas and you will see a very good result. Take herbal ABX as an example, one of my favorite, formulated by Dr. Jimmy Chan, the post-diagnosis master. For each of the formula, we have a clinical application. We have Western and also Chinese therapeutic actions. Especially for the Western part, this is designed for you to communicate with your patients and also their medical doctors, all Western, healthcare professionals, so that you can better communicate with them in a Western term. And also we have a nutrition and lifestyle. So just want to make sure that your patients are eating right, sleeping right when they are on those herbs. Once again, you can just print this document for them. We also have a post-diagnosis by Dr. Jimmy Chan. In addition to that, we have a formula. We have a comparative analysis between Chinese and also Western medicine. This session is written by Dr. Zhang Chen, who has both PhD in pharmacology and also Chinese medicine. Lastly, for each of the formula, we do have case studies. Case studies are written by our customers. They use those herbs and they see a lot of good results. So they write a little story for us. So once again, if your patients are wondering how long they should be on those herbs, you can print the whole document for them and they can read those little stories so they will get better idea about the herbs. Especially for the webinar attendee, if you would like to get a copy of the CD manual, clinical manual in your next herbal package, if you are ordering the herbs, please mention to our staff that you would like to get a copy of the CD manual. If you are ordering online, just go ahead to let us know, put a little message in the box of the comment section at the bottom of the web page. This is for the webinar attendees. And this is a new thing that we have. You can actually browse the clinical manual on the internet right now. If you don't have a CD with you, if you did not install CD onto your computer, right now you can go to this web page and then just enter username and password. Username is Lotus. Password is CD menu. You will be able to browse the clinical manual online over the internet. Okay, any questions about the clinical manuals? No? All right, so let's get back to Dr. Kendall.
Okay, so we can find our place here. Okay, thank you. We got a question from the internet on some things to do with Richard Tan's balance method and selected points. At some point, I will talk about that. Okay, patients rarely feel any pain of needling, and inflammation that you do gets usually restricted around the needle. If it's not restricted around the needle, sometimes it's a nice little perfect circle, which may be due to histamine, but some think it may be platelet activating factor causing this. And another one is where you get a reaction that's kind of wild and it will tend to elongate. In fact, it might even, if there's two needles, it might even go from one to the other. This is due to leukotrienes, highly inflammatory reactants that are triggered due to needling. Triggered due to disease, but then triggered then are apparent during needling by the inflammatory response to the needle. So this means you got too many leukotrienes, and so you have to do something about that. And a lot of it is leaving the needles in longer. The longer you leave the needles in, the more control you get. And then also the leukotrienes gives you a clue what's going on in the body. Yeah.
So that means when you do get the reaction, the wheel and the
Yeah,
these,
string right.
these spread out patterns, so leave them in until that goes away. Is that the suggestion or just?
Well, yeah, you just have to judge, but usually it's going to go away. But it means that longer you leave it in, the more this reaction is going to be normalized, which I'm going to attempt to describe this morning. So these imperceptible reactions, the needle tissue damage, all this stuff, it triggers a potent descending control normalization. Descending control is, remember longitudinal organization? This is the spinal cord, longitudinally organized, the nerves are longitudinally organized, and then has segmental dominance, feeding internal organs and the muscles. So descending control from the brain is what you're triggering in needling, and where you select the points, you're telling the brain where to send the descending control. It's just not random. So as you, the practitioner, are telling the brain and central nervous system to send the descending control specifically here, there, or there. So that way you can focus. You get a very focused result on your treatment. And we're going to go through these things. So how do we get the patient back to normal? Is by using rational selection and use of these neurovascular nodes. Remember these? The Europeans call them acupoints, places the needle. There really are both nerves and vascular components at every single node. They also have more mast cells. They have more fine vessels than non-points. And so these sites are extremely reactive to minor tissue damage, trauma caused by needling. Now, longitudinal organization. First thing the Chinese discovered when they were mapping out all these blood vessels, but these longitudinal blood vessels up and down the body, or longitudinal, the bigger vessels, and also the muscles. They identified all the muscles in the body in these longitudinal pathways, which was really a great gift to us. Because if we know these pathways and we know these muscles, then there's not a single musculoskeletal problem you can't treat if you know these muscles, because it's all right there in the Neijing. And the nerves. Nerves are longitudinally organized and distributed through the body, and then segmental dominant nerves going to the organs and to the muscles, specific muscles. Now, these main vessels are called jingmai for longitudinal blood vessel, but there's collateral vessels. And a Chinese concept is wherever there's a neurovascular node, it's supplied by a collateral vessel of one of the Jing vessels. And these are neurovascular because nerves are there and vascular responses are required there as well. So both these things have to participate. You can inhibit the nerve, nothing works. Or you can restrict the circulation and it won't work. Now, correlated, here's the other great discovery of the Chinese. Even though William Head took credit, showed us experimental proof in 1893, excuse me, of organ-referred pain, the Chinese already described it in the Neijing. And what they did with this, these are segmental effects, that some node on the body is reflecting pain because of a disease organ problem. So you can tell you that's segmental dominance. And so they noted which nodes related to what organ referred pain. But then Solly de Rent did something terrible to us. Is the Chinese described these neurovascular nodes in relationship to the longitudinal distribution, the Jing. So, but Solier decided because of these organ-referred pain that these vessels should be named by that internal organ. And then, for example, we got the anterolateral vessel of the foot, which happens to have some nodes related to the stomach problems. So every node in Solier-Morant's idea of the anterolateral foot part of the body, this part of the body, are called stomach points. Stomach 42, so on and so on. So, and this is a big confusion because and we're going to talk about this later, the nodes that are related to stomach problems are only here. They're not up and down the whole, none of them on the face. So this is a source of enormous confusion. If we're thinking we're needling a point on the knee for a stomach problem, well, actually that might work with Jusan-Lee, but say some other part of the body, it's not going to, if you needle the face for stomach problems, there's no connection. Especially these are all supplied by cranial nerves. And so you'll see that I use the notations for my translation of these Jing, anterolateral foot, anterolateral hand, anterior medial hand, which you relate to the lung, because a lot of these points on that one do relate to the lung. So, so this is complicated things, is that only a few specific points along each pathway actually have organ-referred pain related to that particular distribution. Nodal pathways traversing the visceral pain areas then were associated. This is how they associated what pathway was related to what organ. Those nodes, but only in those areas, like the stomach, you'll see this area. It's only here that you have stomach symptoms. That you can treat stomach. Anywhere else, no, it's not going to happen. Now, segmental dominance basically means that the neural input from the segmental nerves is more dominant than that that's supplied up and down the longitudinal pathways. So if you want to get some very specific response in the body, then it depends on what segmental point you're using. Now with the muscles, fortunately the Chinese gave us a great gift. They identified all these muscles in these longitudinal pathways. So if we know where the problem is, and we know what the segmental level is for that muscle, then we know exactly, if we're going to use points on the back, we know exactly what segmental level to use. And so that would be a proximal point and may have distal points around some area. I mean, local adjacent points around the area and then some distal points on the foot. And then you're going to get consistent results. So this longitudinal organization goes way back to the flatworm 600 million years ago. Found in all vertebrates, starting with the fish around 510 million years ago. So this is a very significant feature in all vertebrates. It doesn't matter if you're a dinosaur, a three-footed dinosaur or whatever, three-toed dinosaur, or a human being. It's the same exact configuration. The genius of the Chinese led to the discovery that kneeling was mediated by segmental and longitudinal relationships. And this is key. If you get this concept, there's no problem you can't treat. No problem. Because this gives you a guide exactly how to take the body's own well-organized system to focus on a particular pathological part in the body. It's almost a no-brainer when you get it figured out. So to enhance clinical outcomes, of course the subtleties of kneeling are complex, but they're well understood. We're going to hear you're hearing today, explainable by known anatomical and physiological sciences. This is not rocket science. Of course, rocket science is not a very precise science, but this has to be. Relies on the application of spinal segmental dominance and longitudinal relationships. It's pretty clear with the humans. We're pretty longitudinally organized. You just look at us, we're all longitudinal, right? Other critters like horses, they're like this, but if you stand them up like us, they're longitudinally organized too. And now, all of you probably already learned all this in acupuncture training, but no one explained it to you by any useful terms, because they were using energy, meridians, invisible meridians, and and to me, I always look at it, it's assault on the Chinese. Sully de Morant, he spent some time in China in the early 1900s. His main thing was learning about the culture and performing arts and stuff, but he also learned some needling. So when he got back to France, he started teaching acupuncture, and most of the stuff, terms he came out, he just made it up. There was no proof of it. So, but this knowledge, if you get these relationships, improves clinical outcomes, patient satisfaction, and more importantly, acceptance in the healthcare system. Because we're not going to get in the system if we're not physiologically based. Unfortunately, the schools refuse to teach physiology according to the required law, and that's why we have all these problems. You all have a little diagram of this. This is the longitudinal organized man, and here he's, whoops. Huh. Okay, I'll use this one. Is it this one? Longitudinal. Here's the sunrise yang, the Yangming area. And here's the Taiyang when the sun's the brightest in the afternoon. If you ever worked on a farm, you really, ever worked on a farm, you really appreciate, okay, too many knobs for me to control. Okay, let's try again. Here, the sun shining on your back when you're in the field all day. It's intense. And then when the sun is below the earth, then it would illuminate this area of the body, this gray area, which is the longitudinal foot and the longitudinal head. But Sully de Morant named them by his vessels, which has caused an enormous amount of confusion. And so I have a little table here to show you the difference is the Chinese, these are Chinese vessels. These are French meridians. A big difference. Vessels, real stuff, or invisible meridians, or vessels, because this is a great discovery of the Chinese, the cardiovascular system. So what he called lung 1, the lung meridian with nodes called lung 1 to 11 is actually the anterior medial hand, namely this, you're looking at the body this way, this part of the body and onto the chest is anterior medial hand 1 to 11. Same applies here to the anterior lateral hand, which he associated with as the large intestine. So all these nodes are called large intestine points. Are there any large intestine indications for any of these nodes? No. I mean, to give you an idea. So this is the problem. So we go from here, then back to the arteries. So the Chinese system is outflowing arteries, return flowing veins. Outflowing arteries to the leg and return flowing veins, and so on and so on. Otherwise, a continuous circulation of this system. So this is causing all kinds of confusion. People say, gee, I'm not getting any results with this point because they're using these false nomenclatures. And so we're going to look at this afternoon. What things are these nodes good for? And we'll go through the anterior lateral foot distribution as an example. Any questions on this? Everybody looks kind of like, is he telling me the truth here? Yeah.
When Chinese are studying this in China, they are not at all referring to the stomach channel as stomach channel.
Yeah, that's a good question. What you find in the Chinese books, they, even though they're aware of Soddy-Morant's nomenclature, they resisted it. When he first said that, they told him, "Oh, you're completely wrong. That's the wrong nomenclature." But he became such a dominant figure, especially when schools, European schools and American schools got started. So the Chinese took the attitude, okay, when they write in English, they'll use Soddy-Morant stuff because that's what Americans think it is. But their Chinese is true Chinese. That's correct. Well, they'll call it by its division, right? You got it. So this has caused a lot of confusion because people are thinking, oh, all I need to know is what meridian, and then I can find out what point on the meridian. But it's caused an enormous amount of trouble. Okay, I'll give you an example because we had the longitudinal man. Then we show you the muscles. This is just one of 12 muscular distributions, and by the way, they're all in my book. This is the lateral foot of the lateral foot, described in the Neijing in Ling Shu 13. And these are muscles, all the muscles they described all the muscles they considered to be in these longitudinal pathways. Some of them, they actually gave them names, but usually it was describing a muscle from its insertion point, because they started at the feet or the hands, from the insertion point to its origin. And they did that consistently for all of the distributions, described their, in that way until they got all the muscles. In fact, this one, even temporalis muscle in there. And how did they verify that these muscles were in these pathways? By finding people who were sensitive responders. For example, you can needle foot lin qi in a sensitive responder, and you can measure minor contractions, muscle potentials into temporalis muscle. So obviously there must be some connection in that pathway. It's in the spinal cord, of course, and the muscle pathways. And so you find it as they did identify called the diaphragm by its name, the diaphragm. They also identified the quadriceps by name. They also named the sternocleidomastoid mastoid muscle by name. And but all the rest of them, they just described them from insertion to origin, up to either starting at the hand if it's a hand distribution or starting at the foot. But these are real muscles. And then when you know this knowledge and you're treating these problems, if you know you have a problem with some of these muscles, you're going to get consistent results. So it's really important to know these muscles. And as I recall, do they teach the muscles in the acupuncture schools? I don't know. They certainly don't teach this organization, right? Yeah. So this is a gift from the Chinese, and we've kind of ignored it. Oh, I have to change the tape. Okay. I could still bloviate, can I? I mean, but it's kind of sad in a way, because to get totally deflected at the very beginning, and then we've been trying to play catch up all this time, and the point I keep making, the Chinese schools, acupuncture schools, are teaching real anatomy and physiology, including surgery, including pharmacology. They're teaching the same courses that are taught in American medical schools. That's why they can take the USMLE 1 and 2 and pass it. Yeah, Mario.
When we talk about like do something here,
Yeah.
big course number 36, which does have.
Oh,
When we talk about the stomach 36,
yeah.
how it affects the stomach.
Yeah.
Points below that are also known, the lower C points have not been known to affect large intestine, lower C 37 and 39. So are you going to talk about that
Yeah,
connection?
this afternoon I'm going to go through that, how the points relate and how the organization. But there is a lot of research in China that verifies most stuff. I got a few examples on the gallbladder. You can needle certain points. You can cause gallstones to be ejected. Other points I'm going to talk about getting other effects. But that's part is in the afternoon. So muscle and nodal distribution determined by propagated sensation phenomena. They still do this in China. They register all the patients that are sensitive responders. Now, what is a sensitive responder? I can tell you because I'm one of them. And when I was still in the space business and going to acupuncture school, and when I had to launch some of these satellites, I had to go down there with the launch crews and stuff. And I was running at that time a lot, so I go down and run on the beach in the mornings early before I went out to the Cape. And all the guys in Florida are running on the sand barefooted, because the sand there is like it's very solid. It's not like the sand here. It's when it's wet, it's like concrete. So I thought I'm going to run without my shoes, right? So I ran without my shoes, and then the next day I had problems because both of my ankles were extremely sore. So I went out and ran again that day, and sure enough, one of the ankles pain went away, but the other one didn't. And so I struggled with it. I went home with it, and in about 3 weeks of dealing with this, I thought the ankle pain should have healed. I'm thinking, gee, I got separation of the Achilles tendon, partial separation or something, and I'm thinking you always think the worst when it's happened to you. So I'm home alone one night. In fact, at that time, my kids were off to college, so I was living alone. And so I decided to needle myself. So one of the things I was interested in, the Chinese were doing a lot of through and through needling. For some of the palm problems, Dupuytren contracture, they were needling from Hagu to toe what?
Toshi?
Yeah, Toshi, yeah. All the way through. So I'm thinking, I'm going to needle from the kidney to the bladder, and so I needle through there. So needle sticking in and sticking out, right? That was pretty good. Then I did Fei Yang, which is one of the great points on the leg, and so I needled that, and that was good. And then I needled posterior lateral foot 55, down here in the middle between the gastrocs. And all of a sudden, as soon as I got the Dutchie, it shot up my leg. When it got up to my ribs, it shot out each rib over the top of my head, hit me in the eye, and all I saw was stars. I didn't expect this. Then I thought, they're going to find my body with these rusty needles. Wondered how did this guy off himself. But guess what? I didn't have any pain in my ankle. So this is what happened. So why was the pain still persistent? Because I didn't get enough stimulation for it to shut the pain off. And that's what the needling does. A very narrow band, high intensity reaction goes right up the spinal cord, up to the brain, and you get your descending control. And that's what you get, especially with that kind of reaction. So I'm a little sensitive about who needles me, but Ted always does a good job if I have a problem. So here's the part of the configuration. Here, pretend this represents the skin, not there. It's got a bunch of neurovascular nodes, actually 3 of them here. And this is the route by which propagated sensation transmits. It goes from node to node to node. And in some people, it'll only go maybe over 3 or 4 nodes. In some, you can get it to go across a big joint like the knee. Maybe it'll go, but only the sensory responders, you can get it to go the whole pathway. And so the Chinese use these people all the time when they're doing a lot of node research. So these are this represents the afferent spinal nerves. These are dorsal root ganglia cells, and they go over to the spinal cord to the dorsal horn. They synapse on and tracks, spinal tracts that go up to the anterior part of the brain, and so you needle here, your signal goes here, and it goes up, and then it's going to go to the thalamus, parietal gray region, and some of that information, when I say some, goes to the sensory cortex. But as you know, some of your patients never feel it. So they're not paying attention to it. The brain's ignoring it. And then it gets processed up in here. We're going to talk about that. And then the body has 2 systems. One is the norepinephrine descending control, and norepinephrine control shuts off the pain and restores homeostasis. Otherwise, the normal acupuncture effect is stimulating descending norepinephrine nerves, and then that shuts off the pain signal, or restores a visceral signal or whatever. Now, the body has another system, the norepinephrine system. Wait a minute. Excuse me, I got this backwards. This is norepinephrine, excuse me. This is stress. Got a stress response. This kicks in. You have an arthritic condition. If a saber-toothed tiger tries to grab you, all of a sudden you have no pain, then you can run. That's the norepinephrine. The one that we use, the acupuncture pathway or needling pathway, is serotonergic. These are serotonergic nerves, and they're dual transmitters. They have enkephalins. So it's a serotonergic nerve, but it squirts out enkephalins at the needling site, and it goes down all the same places where you needle. And then if you get propagated sensation, it goes one node, I already said that. So in needling, you might have, say, this is up on the knee, and this is on the foot. And so you're needling a lot of times nodes that integrate in the same spinal segmental level, or above and below the same common spinal segmental level. So it allows you to direct descending control that you want. Although the practitioner decides from your assessment of the patient, diagnosis of the patient, what should I be doing to solve this problem? And by knowing this, and you already know where the nodes are, right? This gives you a real first cut. So these represent the segmental relationships, because these are all segmental nerves, and this represents the longitudinal organization, these other pathways in the cord. So you give you a kind of a pictographic explanation of these relationships. And it's not real. This is a pretty simplified diagram, because it's far more complicated.
Could you give an example, a specific example?
Yeah, if you, I can give you an example that.
The actual needling
Say you have a gallbladder problem, okay. So you know the gallbladder is approximately, this area approximately overlies the gallbladder, right? So you know right away I can use a couple of local and adjacent points here. Chi-man comes in one, and Uri point, these overlay the gallbladder, okay. But since this is on the lateral foot, one's on the lateral foot distribution, then I'm going to use a distal point that's on the lateral foot to relate to that. I may also use a proximal point that's higher. I could do it on the back that's slightly above this level. So then what that does, say if this was my points overlying the gallbladder and this is the points on the foot, and these are the points on the spine or the back above these 2 points, right? Then what happens? The body sends descending control only to where you needled. So descending control comes here well, we don't show the say the gallbladder's over here. That does something to the gallbladder. And also does something, this whole range of the body. So there you get a wide spread of this reaction going into all these spinal nerves. So that's when you get consistent results. Because did I tell you about the tennis elbow? That early on they'd done some needling tennis elbow. In fact, people saw it doesn't work. They only used local and adjacent points. They got 40%, which is about the same as placebo. Then they decided to use some distal points. So they were using, say, if this is the local and adjacent thing for the elbow. Then they used some distal points on the hand related to that muscle distribution. And so that would be the distal point. This is a local adjacent. So they got 60% success. But when they added a proximal point, could be up on the back of the neck, related to the same segmental level as the problem, they got 90% success. And this is consistent. If you look at all the research that Chinese been doing all these years, very, very consistently using this kind of an approach. And it's consistent because if you know, obviously you know you should know how the body's organized, and these little diagrams give you a kind of a clue so you get a better feeling of what you can do with it. I mean, this is a pretty simple diagram. I published that diagram in 1989. And I don't know if they made copies of that article, did they? There's 2 articles I published in 1989 on the physiological basis of needling or acupuncture. So this is longitudinal organization, segmental dominance. So this kind of thing this is how the body works. All the functions going on in the body, this is the fundamental scheme. Then another detail, a little more detailed here, is it's kind of a blow up of the last chart, but here now we have little diagram showing the skin, and here is a nociceptive nerve, and its neurotransmitter is a bradykinin, and this nerve is kind of interesting. It's a dorsal root ganglia cell. It means the cell body is in the dorsal root of the cord. It has a little pathway back to the site. A little nerve sprig from this nerve sends it one over to the skin, and it also sends one down to the underlying vessels, blood vessels. Now, why is this important? Is when you needle and you stimulate this nerve and you fire it off and it goes over here, it sends a signal across the spinal cord to the other side and goes up the anterolateral tract to the brain, and then you get descending control back down on the other side to do some things which I'll talk about in a minute. So anyhow, the reason for this axon reflex is to squirt some substance P on the capillary bed where the needle is. Now what it does, now this enhances the inflammatory reaction that the body needs to fight the needle. See, the body's a response, I'm going to get rid of that needle. Now, you can do this. You can stick a needle in a finger point or something, small needle, some of these finger points, and the body will eject it. It'll be there, and all of a sudden it starts doing this, doing like that, and it'll pop it out. But it's in some, it doesn't work that well. And you can do this to yourself if you want to do it. So then the other pathway, what is this pathway for? This pathway then triggers the norepinephrine fiber of the local blood vessels below this point to shut down, contract the vein, the local vein supplying the area. So what that does when you contract that blood vessel, it forces stuff out of the, otherwise, here you got artery supply coming into point, but now its outflow is restricted. So what happens, it forces stuff out of circulation, like immune cells, basophils, eosinophils, other substances, out into the tissue area where you just stuck a needle in, punctured a needle in. So it enhances the restorative, in other words, it's fighting the needle. This is how the needle is fought. This is all verified by existing research. There's no, this is not even in doubt. That's a lot, it's more complicated because we have all kinds of immune things, we have cytokines, we have all kinds of stuff, we have leukotrienes, which we're going to get into that too. Okay, now what happens to the descending control? Okay, we needle here, we enhance the reaction, we shut down the vein supplying this, so it enhanced the outflow of immune cells and everything else to help fight off this intrusion, namely the needle. It goes up to the brainstem, gets processed, and it comes down in 5-hydroxytryptamine nerves, which also contain an opiate enkephalin. So the nerve squirts out an opiate, doesn't squirt out the 5-HT. The serotonin doesn't squirt. So the enkephalin gets squirted out onto a bunch of nerves, and these nerves inhibit. One thing that inhibits this pain fiber. It also inhibits the any kind of problem with the internal organ. Although you're not treating an internal organ, you're still going to get a reaction. So that's how we can treat internal organ problems. You get both. You get the organ reaction, you get the superficial body reaction. Always, you can't separate them. And then we have another pathway that shuts off this restricted blood vessel. So that gets shut off. The internal organ thing gets shut off. If there's problems with the internal organ, it gets fixed. And also the other thing is, talked about the gamma loop and the muscle spindles, because a lot of muscle problems, because there's problems with the spindle. You have patients that have paralysis. You treat them, they walk out of the clinic. Like, okay, I know I didn't heal up anything except I turned this gamma loop back on. And so this gets normalized too. So you get all of these things in one little needling point. It's amazing. That's why I call this a miracle. It's built into every single animal. I mean, it's a vertebrate. Not the, I don't know about some of the jellyfish. They're organized different. They're radially organized rather than longitudinally. So that's a whole different story. And I don't know if anybody's needling jellyfish. So then let's take a look at the organ. Say the organ was your problem. You had a stomach problem, right? Now you're going to try to fix the stomach. So you're going to find some good nodes usually on the anterior lateral distribution. Jus and lean is a well-known point, but there are others too. And you may select a proximal point that's on the back, also integrates at the same level as the stomach. And you might use a distal point. So you end up with local and adjacent with the jus and li, distal and proximal. So then this organ gets the benefit of that whole range of needling you did to normalize the function of that organ. But you still get this, and this every time you needle. So these are pretty, I think, straightforward guidelines you can use, everyday clinic. As long as you know where you're trying to decide every time you have a patient, where do I need to send restorative control? That's what you're doing. You're the director. I'm directing this restorative function to this particular problem, or whatever problem. So is that pretty clear? Or? Now, did they copy this figure for you? Okay, good. It's in that book too. Okay, so the microtrauma, see, I call it microtrauma, induces this amplified response. And in the early days when I'm running around lecturing to medical groups and all kinds of people how great needling therapy was, they always say, oh yeah, but a needle can't cause that much trouble. So I had to study. Why is it? So I had put this all together, a piece at a time. Why does it do that? And why does this simple, almost insignificant tissue trauma cause such a great response? So the skeptics always say, well, it's won't produce any useful response. But the needling provokes two great systems of the body. The blood coagulation system, which you can't live without. If that doesn't work, you're dead. You're either going to hemorrhage or clot to death. And the other one is the immune complement system, which you need every day working too. These two systems are the underlying basis of why this simple reaction of putting a little thin needle that you can stick in some hypodermic needle openings, such an incredible response. And then you, the practitioner, you are directing the response. You want to go to a very specific place. That's what you do. So what do we know about this stuff? These interactions amplify and sustain the tissue and neural responses. So it's not you're just going to get a reaction. It's actually little damage, then it just goes through a big, 1,000,000 to 1 amplification in the immune complement system. It's a powerful, because normally your average medical doctor doesn't know about the immune complement system, as it turns out. And so when you start talking about it, they'll say, when I wrote that article for American Journal of Acupuncture in '89, I sent it to one of my buddies who is a specialist in physiology, who had an acupuncturist working for him, so he's very sympathetic. And he sent it back and he said, this is a great article, but it's way over my head. I said, a lowly acupuncture, you're going to write something about, of course, this is my profession, so that's the key. This is your profession. You want it to be right. You want to know, you need to know this stuff. If you want to get consistent results, that's the key. Consistent results.
Okay. Needling provocation is a local provocation.
Right. But then that stimulates a deeper response when we'll go through this. And because they would say, the doctors say, oh, it is, just stick it in, it doesn't do anything. Well, yeah, but you get 1,000,000 to 1 amplification in this. They don't know this. But they should know this because they teach the immune system in the medical schools, but they never thought about it as responding to specific microtrauma. They're thinking, oh, damage. Yeah, you get cut, you break your arm. Oh, yeah, you're going to get a response. But putting in a needle that doesn't even cause any pain sensation, this is a big stretch, right? But believe me, this is true, and I have research to back up everything. That's the key. You have to have evidence. Otherwise, no one's going to believe you. Okay. Now, what are the features of these neurovascular nodes? They are distributed longitudinally on these pathways, and they have collateral vessels, so the blood vessels that supply each of these nodes. In fact, the name of the nodes in Chinese, like Fei Yang, which is on the posterior lateral foot distribution, is called the Fei Yang vessel, otherwise the low vessel. These points are named by the vessel, by the collateral vessel supplying the node. So we think, well, it's just the name of the node. No, actually it's the name of the vessel supplying the node. I mean, that's in the Neijing. Now, the corneum stratum of the skin is slightly thinner with lower electrical resistance where these nodes exist. So that gives you a clue. Now, why would that be? So it's because there are more fine vessels and also nerves at these nodes. So where you have warmer spots on the skin, the corneum stratum is slightly thinner. And you can actually, a lot of nodes, when you get a depth out, you can just slide your arm down the longitudinal pathway and it will stick on the node because it's a slight, almost non-perceptible indentation. The Chinese all know this. I mean, they've been doing this for years. So then we go on. Then these nodes contain more sensory nerves and non-sites. We got tons. When I say tons, thousands. In 79, I already had study reports from China involving over 100,000 subjects with actual research data. And I still couldn't get the acupuncture school to listen to me. Oh, no, it's qi, it's French meridians, and all blah, 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 blah. So the Chinese have been, fortunately for the Chinese, they did all this research. And of course, I reference them in that paper. I think I have 253 references in it, that 89 paper. Have more fine vessels with sequestered mast cells. Now, why are mast cells important? And also some of these points are motor points. You know, the motor points, the Fei Yang is a motor point of the lateral soleus. And Ju Bin is the medial motor point of the medial soleus. They have more mast cells. Mast cells are these inflammatory cells. They're in the tissue. They don't float around like this. Equivalent to basophil is circulation in the body. The mast cells are in the tissue. They're kind of laying there next to the vessels, like flattened out things next to these vessels. So when you damage these fine vessels, every time you stick in a needle, you're damaging microtrauma, these fine vessels. And what does it do? It damages these mast cells. Heparin in the cell. But when it gets out, the histamine does what? I'm going to give you inflammation. And so what does the heparin do? The heparin goes over and inhibits the production of thrombin. Thrombin is a blood clotting thing. But when you put that little needle in there, it causes little damage, you don't want coagulation because you want these immune cells to come in there. So heparin shuts off impairs production of thrombin. And so it's improving the solubility or the circulation of the tissue stuff. Later, that's going to get shut off because you got to shut that off during the control phase because you don't want that because you might start hemorrhaging or something if you get too much of this stuff. Okay, okay, you're hanging with me so far? If I get something you don't understand, you're free to ask questions. Okay, now, what about clinical application? This is the only reason we need to know this. We want to be good clinicians. We're only in business to help people. My impression of people in acupuncture, as opposed to other medicine, they really have a desire to help people. I mean, it's really something that they really want to do. So anyhow, needling provokes a known cascade of complex tissue reactions and neural reactions. It's not just, okay, I get something, I get one thing. No, it's a big, well-known cascade of activities. So if you hang in there, we'll try to get through these things. So what's it influenced by? It's influenced by the depth and the strength of the needle manipulation, insertion and manipulation. Yeah.
What about gauge?
Gauge, also gauge. A lot of people like to use, I was raised on Chinese needles, so I'm big into big gauges. But people say, oh, no, but I never had a patient respond adversely to the Chinese needles. It's all a matter of how you insert them. And I had a real classic case one time. A Chinese couple came to the clinic on a Saturday morning. They had been down at Redondo Beach, and they were playing volleyball, and she got a spasm in her back, and she was in absolute misery. And she had spasm on the right side, all the spina erecta for about a foot, or about an inch higher than the other side of her back. And she was just in absolute misery. And the husband was going, she's afraid of needles. That means he's afraid of needles. And so don't worry, she's not going to feel anything. So anyhow, I put these needles in her back, put them in, and she raised her head off the table and says, be sure and let me know when you put the needles in. These are heavy gauge. These are the regular Chinese needles. So it's all of how you do it. And so you have to know how far to go in, strength of stimulation, and because you want to control the amount of damaged products, and of course you're controlling it by node selection of where you're trying to get the reaction to start and where it to go to. So you're always in control. That's the good part. Western medicine, that's not always the case, because some of these drugs and stuff, it's a crapshoot. You don't know what's going to happen. So also influence how long you leave the needle in. If you're treating hypothyroidism, you can't leave the needle in there but more than a few minutes. If you're treating urticaria, I mentioned earlier, acute urticaria, you need the needle in longer but less stimulation, because they already got too much inflammatory reaction. So you get the needle in quietly, and then you let the needle stay in longer. So these are things that you control. There's not much you can control except these. Node selection, how you stimulate it, and how long you leave the needle in, and then the number of treatments. So selecting these neurovascular nodes in terms of local and adjacent, I'm a simple guy, so I need to reduce things to something I can understand. Local and adjacent, that means if I got a gallbladder problem, I got local and adjacent points, or stomach, maybe here or in the back. And then proximal, that means some node that integrates in the spinal cord at a slightly higher level than this. Like I'm talking about the tennis elbow. When you're up on the spine as the proximal, and you're doing local adjacents here, and then distals down in the hand. So that's an example. This will get you consistent results. Consistent results. Now, there's a lot of schemes out there in the world, but this is good clinical results. See, because what you want consistent results, because when you do, did I tell you the guy who was about the contracted muscles, and I just needed that Jinso? That guy sent me 200 patients. because he would go somewhere to a party. And I said, where the hell you been? Oh, I was in the hospital for 10 days because I had this. Oh, what happened? Oh my God, you look like, well, I went to this acupuncture. One treatment, the problem went away, and then he gave me 2 more treatments just to, he said, it can't possibly be true. I swear, he sent, everywhere he'd go, he would tell people because it's such an amazing story. And the people just start coming in. And then you have other miracle cures, and they start coming in. So that's what happens. Now these responses, oh yeah, sure.
Is there a sequence to your distal or proximal or local needling? Do you start with a distal needling or local needling or?
No, that's a good question. Usually, it really doesn't make any difference. But the key is, and I learned this from everything I know I learned from the Chinese, by the way, is that the Chinese, they say, usually you're going to do local adjacent because you don't want to put, say, needles somewhere or needles here, and then when you're doing it, and then you're bumping into those needles. So it's a matter of the ease of making certain the patient's not disturbed if you should inadvertently, and of course you never bump into the needle. So you just use your own judgment. What is the best access to the patient without causing any trouble? And that's important. People don't ignore it. They got a point in the foot and they're reaching over here and catches on a sensitive point on the foot and the patient jumps off the table. So anyhow, these tissue reactions is a good part. It's a set order. It's a well-known order. It's not, as I said, rocket science. This is something better. You know, they know what it is. And initial response, when you put the needle in, is going to mount a strong defensive reaction because the body doesn't like to be violated like that. So it has all these things at play. We're going to break in 10 minutes. What was I talking about? Anyhow, it's going to get a strong reaction because it's evolved. Now, how did it evolve? My story goes like this. When the earth was created or happened, and then plants came along and started growing on the planet. And they're beautiful plants and all this stuff with flowers and stuff like that. And then insects came along and started eating the plants and eating then what did the plants do? They grew thorns and stickers. Because aqueous, meaning needle, also means, or xie means thorn. So then animals had to develop this defensive system to keep up with the plants. So we could keep eating the plants. That's why we're still there, we're eating plants. Well, some of us only eat plants, but then, so it's a very well developed, after all these millions of years. Important to keep blood clots from forming so immune cells can flow. So you're putting a needle in there, but you don't want the needle to cause a coagulation reaction because you want to keep the blood flowing into the area that you're needled. So what the blood system does, it during this induced inflammatory reaction, which is neutralizing the final phase. So what it does, as I said, it inhibits, heparin inhibits the thrombin being created, so you don't get the blood coagulation. So everything has this time dependent sequences. First is, oh yeah, sure. Yeah.
Let's see where I was here. As far as the inflammatory reactants being neutralized in the final phase, now are you talking about the final phase of the response, the overall response, or just the time when the needle's in, like you say for hypothyroid?
No, it's actually why the needle is in. It'll go through inflammatory, which I'm going to got a table here real quick. It's a very well-known time-dependent sequence.
Now, how does that happen as far as like hypothyroidism? You said you only leave the needle in a couple of minutes versus something
okay. In the case of the thyroid, in case of that problem, where the person is already have problems, then you can't leave the needles in longer. So you're treating them strongly with strong stimulation. So by the time you take those new needles out, the restorative reaction is not completed, but you don't need the needle. It's still going to complete.
Okay, so it just completes it itself.
Yeah, right. Yeah.
Okay.
But I got a little table in here that kind of, yeah, if you know this sequence, which everybody should know, then it gives you a very good handle how long should leave the needle in, and what's going on. So all these time dependencies, vasodilatation, nociceptive nerve excitation, chemotactic reactions, solubility activities, the solubility to keep the blood flowing, predominate during the initial phase of the needling response. And then during the restorative phase, or the tissue repair, inactivation of these reactants predominate during the intermediate and latter phases of the reaction. Because you got all these inflammatory reactions, so then you have to shut them off. So when you're finished, what you disturbed is normalized, but what happened in the process, you resolve some pathogenic problem, pain, organ function, or whatever it is. So that's why I call this is a miracle of medicine. So you just need to know when and how to do this stuff. Okay, here's the table. I think you should have a copy of this table. Is it in there? Well, it's a small one. It's kind of small, but. Now, there's a system called the blood coagulation system. And there's a bunch of these zymogens floating around in the bloodstream all the time. And they're just waiting for some damage or something to happen. And they're going to come in and do something. And the one that we are stimulating is Higman factor 12. And what this factor does, when it detects minute tissue damage in the blood system, it gets activated, then it becomes factor 12A, and then it brings in all kinds of reactions going on to respond to that little insignificant tissue trauma. Insignificant, and respond. So this is our initial needling response. And what does it do? Excuse me, I keep wanting to push around. It fires off the nerve fiber, bradykinin. It actually produces bradykinin as a neurotransmitter of these pain fibers. Complement, immune complement, degranulates mast cells. So the mast cells are degranulate and dumps in all this histamine right in the tissue damage area. So you get a lot of vasodilatation. And then kinin protease from the mast cells also goes back and it's an amplification loop, an unstable feed-forward loop, then causes more of the blood coagulation system to react. So that's why you just a very minute tissue damage, all of a sudden you get a big reaction. Then part of nociceptive excitation is bradykinin 2 excites the substance P, A, delta, and C fibers. And these sustain a reaction by axon reflex, as I mentioned that little figure earlier, where you got to go onto the capillary bed and where the needling is, and it squirts out substance P, acting on tissue and sympathetic nerve fibers. Then they're also chemotactic. Part of this is a chemotactic phase where now additional immune cells are attracted because the mast cells are stuck in the tissue. They're already there where you needle. But now it has to bring in these basophils, which are the blood equivalent of the mast cells. It floats around in the blood. So it's just waiting to get some signals that there's tissue damage. They come to where you just needled. The battery's going dead here. Where you needled, and it's going to dump all these basophils right into the area where you just damage this tissue. So it's going to enhance this inflammatory reaction, an immune system reaction. Neutrophils come in, monocytes come in, and eosinophils come in. Now, eosinophils usually are immune cells associated with the gut and gut disorders, but in this case, eosinophils, in the case of needling, eosinophils have a role in reducing the most inflammatory products in the body, namely leukotrienes. So this comes into play too. And then the solubility phase activates C3 and C1. These are the immune complements. Lyses fibrin, because you don't want the blood flow restricted. Inhibits thrombin, as I told you, disaggregates platelets. Then the platelets are important because the platelets are going to initially, it's going to keep platelet activating factor on the cell walls from accumulating where the needling tissue is, because you want that to stay active for a while. So initially, that's inhibited, and then also it clears all the tissue damage products, the body, these immune cells and all this stuff. Then we get to the tissue reaction or tissue repair phase, attraction and aggregation of and degranulation of platelets, local vascular constriction, and formation of fibrin and clots. So it heals up, and then the platelets are attracted to the damaged hole in the vessel, so it seals that up. And then finally, inactivation, degradation of Hagman factor 12, heparin and heparin sulfate, these slow reacting substance anaphylaxis discovered by Sir Thomas Lewis in 1935. We've known about these things a long time. They're now called leukotrienes, and also deactivating histamine inhibits formation of arachidonic acid. Arachidonic acid is the key to producing these inflammatory agents, which we'll get to that. So any questions on this? Yeah.
So chemostatic.
What?
The chemostatic level?
Yeah, tactic, huh?
Tactic level. How much of a systemic effect is that, especially like with the eosinophils having to do with gut allergies and respiratory conditions? How much are you going to affect the entire system?
Well, the key is to bring all this stuff in, but you get systemic effects, because when you have too many leukotrienes, you've probably got rheumatoid arthritis or other bad inflammatory diseases, and there you're trying to get a systemic effect. So you are getting a systemic effect. Some of it's local effect with the nerve, but these other things are in the bloodstream, are floating around.
So you're activating this response systemically, so you're going to have spontaneous improvements in other areas of the body at the same time?
Well, you're treating rheumatoid arthritis. You're only treating certain parts of the body, but the effect is affecting the whole. Those things are being circulated through the blood.
So other joints can be affected and can
See,
reduce
because
the pain.
the mast cells, the mast cells started, but these cells, they're just dumping in the area where the tissue damage is. Now, they may be also in areas where there's already existing inflammation. Because you find that too. You got an inflamed joint, these guys are there. They're causing the inflammation. And so you start with a needle, you cause some tissue damage, all this stuff, and then it miraculously shuts it down, and you restore to where you were. So this is really important. So what does this mean? Length of needle insertion is critical. Depth of insertion, the amount of tissue damage you do. These are all subtle but critical factors. Break time. Okay, you get a break.
Okay, so let's take a short break this time because we still have a lot of information we need to go through
we have
in the
about
morning.
another hour to
So
go.
let's take a break for 5 minutes. Come back at 12:15.